Your doctor looks at the monitor, smiles, and says, "Perfect. Your blood pressure is finally where we want it." You leave the office feeling relieved, maybe even proud. You have done what you are supposed to do. You took the medication. You followed the plan. The number is where the textbook says it should be. And 3 nights later, you stand up from your bed at 2 in the morning, take 4 steps toward the bathroom, and the floor comes up to meet you. A fractured hip, a hospital, a rehabilitation facility, and a slow, grinding battle to get back the independence that, 6 months ago, you did not even know you were at risk of losing. Here is what nobody tells you. For millions of adults over 70, achieving so-called perfect blood pressure is not the goal. It is the danger. And the research that proves this has been sitting in major medical journals for years, while the guidelines that govern what your doctor tells you have not caught up. I am Dr. Adriana Markson. I am a physician specializing in internal medicine and cardiovascular health, and I have spent over 2 decades watching this gap between evidence and practice cost people their independence, their cognitive function, and in too many cases, their lives. Today, I am closing that gap for you. I am going to show you the blood pressure range that the research actually associates with the longest survival in adults over 70, the 3 physiological changes that make the standard target dangerous after a certain age, the silent test that your doctor should be doing at every visit, but almost certainly is not, and the exact numbers, by age group, by medical history, by individual risk. So you can walk into your next appointment as an informed participant rather than a passive recipient of whatever the algorithm on the computer screen says. Before we get to numbers, you need to understand something fundamental. Your cardiovascular system at 75 is not just an older version of your cardiovascular system at 45. It has undergone 3 structural and functional changes that completely alter what blood pressure numbers mean for your health. Most doctors know these changes exist. Most treatment protocols do not account for them. The first change is arterial stiffness. Your arteries are supposed to be elastic. They expand when the heart pumps blood into them, absorb the pressure wave, and release it gradually. That elasticity is what allows your vessels to regulate pressure smoothly throughout the body. After decades of use, arterial walls lose that elasticity. The collagen fibers that give them flexibility begin to cross-link and stiffen, a process called arteriosclerosis, distinct from the plaque buildup of atherosclerosis. Stiff arteries cannot absorb pressure. They transmit it directly. And critically, they require a higher baseline pressure to ensure adequate blood flow reaches the organs that need it most: the brain, the kidneys, the heart itself. What this means in practice: the blood pressure that adequately perfuses your brain when you are 45 may be insufficient at 75 because the delivery system has changed. The pipe is stiffer. The pump has to push harder to get the same flow to the same destinations. The second change is baroreceptor decline. Inside the walls of your major arteries, particularly in the carotid sinus and the aortic arch, sit tiny pressure sensors called baroreceptors. Their job is to detect rapid changes in blood pressure and signal the brain to compensate instantly. When you stand up, gravity pulls blood downward. Your baroreceptors detect the drop, fire a signal, and within 1 to 3 seconds your heart rate increases slightly, your vessels constrict, and pressure is restored. This process is so fast in a young person that they never notice it. But baroreceptor sensitivity declines progressively with age. The sensors become slower and less accurate. In a person over 70, that compensatory response can take 10, 15, even 20 seconds. And in those seconds, if baseline blood pressure is already low because of aggressive medication, the brain receives insufficient blood flow. You feel the room tilt. You reach for something solid, or you do not reach fast enough. The third change is altered drug metabolism. The kidneys and liver process medications more slowly after 65. A blood pressure medication dosed for a 55-year-old patient will remain active in the body of a 75-year-old patient for significantly longer, producing deeper and more prolonged effects. Many older adults are on doses calibrated for a physiology they no longer have, in a body that processes drugs far more slowly than when those doses were established. 3 changes. 3 reasons why the number that protects a 50-year-old can harm a 75-year-old. And yet, the guidelines that most doctors use today were built primarily on data from middle-aged adults, then applied universally across every age group. That is the gap. That is what this video addresses. A major study published in JAMA Internal Medicine followed 15,342 adults over the age of 75 for 5 years. These were not handpicked, healthy research subjects. These were real-world older adults, people with diabetes, prior strokes, heart disease, varying levels of frailty. Researchers tracked their average systolic blood pressure over those 5 years and mapped it against outcomes: mortality, hospitalization, falls, kidney function, and cognitive decline. Here is what they found, and I want you to hear these numbers carefully. The group with systolic blood pressure below 120, the textbook target, had a 28% higher risk of serious falls resulting in hospitalization. They had higher rates of acute kidney injury. Their cognitive decline scores were worse, and their overall 5-year mortality rate was 14% higher than the group immediately above them. The group with the lowest mortality, the fewest falls, the best preserved kidney function, and the slowest rate of cognitive decline was the group with systolic blood pressure between 130 and 140, not below 120, not the perfect number, the moderate range, the range that, in a standard clinic visit today, would trigger a prescription to bring it lower. The group above 150 showed the expected problems: elevated stroke rates, more cardiovascular events. High blood pressure is genuinely dangerous. Nobody is arguing otherwise. But the data shows clearly that the relationship between blood pressure and outcomes in older adults is not a simple downward slope where lower is always safer. It is a curve. It has a bottom. And pushing past that bottom does not protect people. It harms them. I want to paint you a picture that I have seen play out, in variations, more times than I can count. A 77-year-old woman, I will call her by the first name Margaret, comes into a routine checkup. Blood pressure, 144/82. Her physician, following standard guidelines, adds a second antihypertensive medication. 3 months later, Margaret's blood pressure is 121/74. The doctor is satisfied. Margaret feels, she says, a little more tired than usual, but she assumes that is just getting older. What is actually happening? Margaret's sitting blood pressure is 121. But when she stands up from a chair, her baroreceptors, already slower than they were at 55, cannot compensate fast enough for the medication-deepened baseline. Her standing blood pressure drops to 94/58 within seconds. Her brain, which is accustomed to a higher pressure to maintain perfusion across stiffened arteries, is receiving inadequate blood flow every time she changes position. She feels the familiar brief lightness. She sits back down. She adjusts. She compensates. She tells no one, because her blood pressure at the doctor's office looks perfect. 6 weeks later, she gets up at night to use the bathroom and does not make it back. The fractured wrist from the fall leads to an emergency room visit, a surgery, a rehabilitation stay, and a conversation with her family about whether she can continue living independently. Her blood pressure at the time of the fall? 121/74. Textbook perfect. That is not a failure of the patient. That is a failure of a one-size-fits-all target applied to a physiology it was never designed for. Here is what nobody told you, and here is what most doctors are not doing at every visit, even though the evidence says they should. There is a 3-minute test that directly measures whether your blood pressure medications are putting you at fall risk right now. It is called orthostatic vital sign measurement. It requires a blood pressure cuff, a flat surface, and 3 minutes of your time. You can do it tonight. Here is the protocol. Lie flat on your bed or a couch and rest quietly for 5 minutes. Do not skip the 5 minutes. Your body needs that time to equilibrate. After 5 minutes, take your blood pressure while still lying down and write down both numbers. Now stand up and take your blood pressure immediately within 60 seconds of standing. Write down those numbers. Now compare them. If you're systolic, the top number dropped by more than 20 points when you stood up, or if you're diastolic, the bottom number dropped by more than 10 points, you have what is clinically defined as orthostatic hypotension. That is the diagnostic threshold. That is a medical finding. And if you find it, it needs to go into a conversation with your doctor because it means your standing blood pressure is falling into a range where your brain is not receiving adequate perfusion every time you change position, which is dozens of times a day. To make this concrete, if you are lying down and your blood pressure is 128/76, and when you stand it drops to 101/62, that is a 27-point systolic drop. That is orthostatic hypotension. Your sitting pressure looks controlled. Your standing pressure puts you at serious fall risk. These are two entirely different clinical pictures from the same medication, the same patient, and the same body, and only one of them is being measured at the doctor's office. Ask yourself honestly, when was the last time your doctor took your blood pressure both lying down and standing, in the same visit? If the answer is never, or if you cannot remember, that is a conversation you need to have. You are not being difficult. You are being informed. That test costs nothing and takes 3 minutes. Its absence in routine care is a gap that is injuring people every single day. Now let me give you the actual numbers, what the current evidence supports as reasonable targets across different age groups. I want to be clear that these are frameworks for a conversation with your doctor, not absolute rules applied in isolation. Your individual picture depends on your medical history, your medications, and your functional status. But you deserve to walk into that conversation knowing what the research says. For adults aged 65 to 74 who are generally healthy with no major complicating conditions, a systolic range of 130 to 140 is supported by the evidence as providing meaningful cardiovascular protection without the risks that come from pushing lower. For adults aged 75 to 84, the evidence shifts. The data supports a systolic range of 135 to 145 as optimal for this group. This is higher than the younger cohort, and it is higher intentionally because this group has greater arterial stiffness, slower baroreceptor response, and altered medication metabolism. The target should reflect the physiology, not override it. For adults over 85, or for those who are frail regardless of age, a systolic range of 140 to 150 is frequently the most appropriate target. At this stage, fall prevention and preservation of independence, cognitive function, and quality of life take precedence over aggressive blood pressure control. A stroke from uncontrolled hypertension is a real risk. A fall from overtreated hypotension is an equally real risk. The goal is to navigate between them with precision, not to optimize for a single number. Now, the diastolic, that bottom number receives far less attention than it deserves. For older adults, diastolic pressure should generally remain above 65 and ideally between 70 and 85. Diastolic pressure is the pressure in the arteries during the heart's relaxation phase, the filling phase. When diastolic pressure is very low, the heart muscle itself receives inadequate blood flow during the brief window between beats. If your diastolic is consistently below 60, that warrants a specific conversation with your physician regardless of what the systolic reads. Here's where this becomes nuanced in a way that matters for real people. 2 patients, both 81, both with systolic blood pressure of 156/90. Same number, completely different situations. The first patient has mild congestive heart failure, stage 3 chronic kidney disease, and moderate osteoarthritis. She lives alone. For her, aggressive blood pressure lowering carries compounded risks. The medication that lowers her pressure can further reduce kidney perfusion in already compromised kidneys. The resulting dizziness from orthostatic drops can cause falls that, given her osteoarthritis, are particularly dangerous and potentially life-altering. For her, the right target may be 140 to 145 systolic, achieved gradually, with one medication at the lowest effective dose, with orthostatic measurements at every visit, and with explicit instruction to report any dizziness or lightheadedness immediately. The second patient at 81 walks 3 miles every morning, takes no other medications, has no cardiac history, and has normal kidney function. The same blood pressure of 156/90 may warrant more active treatment in her because her physiology can tolerate it and because her cardiovascular risk profile means the benefit of treatment outweighs the risk. Her target might reasonably be 130 to 135 systolic, approached slowly with careful monitoring. Same age, same blood pressure, opposite treatment strategies. This is what personalized medicine looks like. This is what the guidelines do not always make room for. And this is why the number on the screen does not tell the whole story. You may be wondering, if the research is this clear, why is my doctor still telling me I need to be at 120/80? The honest answer is that medical practice changes slowly. The landmark trials that established aggressive blood pressure targets were conducted primarily in middle-aged adults. Those results were extrapolated to older populations without the data to support the extrapolation. And once a guideline is established, it takes years, sometimes a decade, for updated research to change what practitioners are trained to do. There is also a systems problem. A physician with 15 minutes per appointment, 20 patients per day, is working from a checklist. The checklist says blood pressure target below 130. The number is above 130. The checklist says prescribe. The nuanced, individualized conversation about what that number means for this specific 78-year-old with this specific medical history, that conversation does not fit in the 15 minutes. Not because your doctor does not care, but because the system they are operating in does not build the time for it. Which is why you need to bring that conversation with you. You need to walk in informed. Here is your complete action protocol. 5 steps, starting tonight. Step 1. If you are over 70 and on blood pressure medication and do not have a home blood pressure monitor, get one. They cost approximately $30 at any pharmacy. Beginning tonight, measure your pressure twice daily, once in the morning before any medication, once in the evening. Do this for 2 weeks and keep a written log. This gives you and your doctor a far more accurate picture of your true average pressure than the single reading taken in an office setting. Step 2. Perform the orthostatic test I described. Lying down for 5 minutes, then standing immediately and measuring again. Do this on 3 separate days. Record the results. If you find a drop of more than 20 systolic points or more than 10 diastolic points, that is a finding that must go into your next medical appointment. Step 3. Audit your symptoms honestly. Dizziness when standing. Lightheadedness when rising from a chair or bed. Unexplained fatigue in the mid-afternoon. Difficulty concentrating that is new or worsening. These are not just signs of aging. They may be signs that your blood pressure is being held too low for your physiology. Write them down. The specific symptom, the time of day, the circumstance. Patterns are data. Step 4. Before your next appointment, prepare 3 questions. What systolic target is appropriate for my age and medical history specifically? Have you checked my orthostatic blood pressure, and if not, can we do that today? Are there symptoms I should watch for that would indicate my pressure is being managed too aggressively? These are not confrontational questions. They are the questions of an informed patient. Any physician worth their training will welcome them. Step 5. If you experience side effects from blood pressure medications, dizziness, fatigue, brain fog, cold extremities, report them at your next visit and do not dismiss them as unavoidable. These symptoms frequently indicate that the dose or the target can be adjusted. In many cases, a modest upward revision of the target from 120 to 135 systolic, for example, resolves the symptoms entirely while still providing meaningful cardiovascular protection. Here is what you now know that most people your age do not. The blood pressure target of 120/80 was built for a 50-year-old. It was not built for your physiology. For adults over 70, the research consistently points to a moderate range, 130 to 145 systolic, depending on age and health status, as the zone of maximum protection. Below that range, fall risk rises. Kidney function declines. Cognitive function deteriorates. Mortality increases. You know that orthostatic hypotension, blood pressure that drops dangerously when you stand, is often more immediately life-threatening than the number your doctor sees on the screen. You know how to test for it. You know what the results mean. And you know that this test is not being done routinely, which means the data it would reveal is invisible to your care team unless you surface it. Each of these factors, arterial stiffness, baroreceptor decline, medication metabolism, creates risk on its own. When all three converge in a patient whose blood pressure has been pushed below the range their physiology requires, the result is not a success story. It is a fall waiting for a trigger. This is preventable, not by ignoring blood pressure, by understanding it with precision. Your heart has been working for you, without rest, without acknowledgement, beating approximately 100,000 times every day for every year of your life. It does not need to be pushed past its limits by a target that was never calibrated for it. It needs to be understood. You are not broken because your blood pressure runs a little higher than a 50-year-old's. You are not failing because the number does not match the guideline. You are a person with a physiology that has earned its complexity, and you deserve a conversation about your blood pressure that reflects that complexity. Start tonight. Do the orthostatic test. Begin the 2-week log. Write down the questions you are going to ask. The information you now have is not just knowledge. It is leverage, the ability to walk into a room where you have always been the patient and walk out having been a participant. I am Dr. Adriana Markson, and I will see you in the next video. If this gave you something you did not have before, a number you now understand differently, a test you are going to do tonight, a question you are going to ask your doctor, please like this video. That single action puts this information in front of other adults over 70 who are sitting right now with a blood pressure reading they do not fully understand. Subscribe to this channel. Every week I bring you evidence-based medical information designed specifically for adults in their 60s, 70s, and 80s, explained in plain language, without agenda, without products to sell. Leave a comment telling me one thing. What did you believe about blood pressure targets before this video that you now see differently? Write it out. It helps me understand what is missing from the conversations people are having with their doctors, and it helps the next person who finds this video know they are not alone in having that gap. And share this with someone over 70 in your life whose doctor recently told them their blood pressure is finally perfect. You may be giving them the single most important piece of health information they receive this year.